Hi everyone, this is a voiceover lecture on postpartum adaptation and nursing assessment. In this lecture, we'll cover the physiological changes that happen during postpartum and the postpartum assessment. Postpartum. What is postpartum? Well, postpartum is commonly defined as the 6 weeks after childbirth. It is the period that occurs immediately after delivery of the infant, and it lasts for 6 weeks in moms who had a vaginal delivery and 8 weeks in moms who had a C-section. And so this is a crucial time for the mom and her baby. The patient will experience many changes both physically and emotionally. Most women are discharged from hospital within 1 to 2 days if they delivered vaginally, and for moms who had a C-section, they are discharged from hospital within 3 to 4 days, as long as there is no complication. So now let's take a look at some of the changes that happen during the immediate postpartum, during postpartum in general. So there are changes that happens to the vital signs and blood volumes. There is decreased blood volume. And so due to this decreased blood volume, a patient, the heart rate will be around 50 to 70 beats per minute. So you'll see bradycardia rates of 50 to 70 beats per minute. And this is due to decreased blood volume and increased stroke volume. Also, the blood pressure remains consistent with baseline blood pressure. And this is very important because if you have a patient, you need to know your patient's baseline blood pressure because a patient can also experience preeclampsia during the postpartum period. So knowing their baseline is very, very important so that if there is any deviation from their norm, you should be able to pick it up immediately. Temperature elevations may occur within the first 24 hours postpartum, and that is totally fine. So if you check your patient's temperature and it remains elevated within the first 24 hours, that is totally fine. However, after 24 hours, if their temperature remains elevated, now that could be an indication of endometritis, and usually that is seen post 24 hours during the postpartum period. Respirations usually remains unchanged. The white blood cell count is often elevated after delivery, and also there is activation of clotting factors which predispose the patients to thrombus formation. And this is why one of your assessments in the postpartum is to check the patient's calf, because if there is a calf pain, inflammation of the calf, that will be an indication of DVT. And the risk the risk of thromboembolism usually lingers up to 6 weeks. Patient experiences diaphoresis after delivery, and they may have chills, night sweats within the first 24 hours post-delivery. So this is called postpartum chills or shaking after delivery. And this is really, it happens because a few days ago I had a patient who delivered, and the patient started shivering while she was breastfeeding. She said to me, "Why am I shivering?" So I explained to her that it's not uncommon for moms who had a baby to shiver. So while I was talking to her, I noticed that she's now shaking more. So I had to take the baby away from her, put the baby in the warmer. And this woman was shaking vigorously that I had to call for help because we actually thought that she was having eclampsia, but her pre-eclamptic labs that we sent all came back normal. So it was just a severe postpartum chills that she had, and that is totally fine. It kind of resolves on its own. So you give warm blankets to the patient if they are, experiencing that chills. So basically, every system needs to go back into normal, and usually that takes about 4 to 6 weeks. Also, hormones do experience change. The estrogen and progesterone will decrease. Remember, progesterone is the hormone that is responsible for the maintenance or upkeep of the pregnancy. So with the delivery of the placenta, the hormone, the progesterone and the estrogen level will drop, and the oxytocin and prolactin level will increase. Insulin, cortisol, and growth hormones will return to normal, as well as the thyroid level. The breast. The breast for the first day or two after delivery should be soft and non-tender. After that, the breast changes now depend largely on whether the mom is breastfeeding or not. So during your assessment of the breast, you want to assess mom, ask her if she's breastfeeding or bottle feeding. You want to inspect the nipples and palpate for engorgement or tenderness. Or if you look at this image, you'll see that a normal nipple, you see pictures of the nipple. We have a normal nipple, which is everted, and we have a flat nipple, and we also have the last one that is an inverted nipple. So these are different types of nipples. A woman with a normal nipple or everted nipple, if she's breastfeeding, will not have a difficulty breastfeeding. But moms who have flat nipple or inverted nipple will need a little bit of help with their breastfeeding. So you want to also inspect the nipples for redness, cracks, bleeding, blisters. You want to make sure that there is no bleeding coming out from the breast. Sometimes you may see moms who may experience some sort of blood or bleeding coming out from their breast, and it's usually due to ruptured capillaries. As long as it's not significant, if it's too many or too much blood coming out, then they have to be seen so as to rule out any kind of breast cancers. You also want to ask the patient if they have any history of breast surgery. Now, patients who've had breast implants, silicone reduction, any kind of breast surgery, they can breastfeed. However, for you to know how much, if they can exclusively breastfeed, of course, they cannot exclusively breastfeed because these are the patients who will have to supplement formula in their feeding of the baby. So you want to know the extent of surgery. Where was the incision made? How much tissues or ducts were removed? So you want to check all those things in order for these moms to feed the baby well, because if the baby is being breastfed and the baby is not getting enough, that baby will experience what is called failure to thrive, and that will not be good. So you want to always remember that when you do an assessment on the patient. Of course, as you're looking at the breast, you want to make sure that there is no dimpling of the breast. Any dimpling on the breast will be an indication of cancer. You're looking at the shape, the size, and of the breast to make sure that it's symmetrical. The breast should be palpated for firmness and tenderness, which indicate vascular and lymphatic circulation that may precede milk production. And initially, the breast may feel lumpy and various lobes begin to produce milk. So that is all normal. Of course, you want to find out from the patient if they've had any past experience of nursing, because moms who have had those experiences in the past will have, they'll find it easier to breastfeed because they know what to do. If you have moms who are first-time moms, they will need help. So especially, they will need help to latch the baby onto the breast. Now, breastfeeding should be very comfortable. It should not be painful. If a patient is complaining of pain while she's breastfeeding, that baby is not properly latched on. The key to breastfeeding or effective breastfeeding is largely dependent on achieving proper latch. So if the baby is properly latched onto the breast, breastfeeding should be comfortable. Mom will get used to it, the baby will get used to it. So you want to pay attention to your first-time moms who want to breastfeed so that you can encourage them and support them in order to achieve their goal. Lactation. Lactation is the secretion of milk from the mammary glands, and this is a natural process. However, lactation is inhibited until the placenta is expelled, because that is when the levels of progesterone and estrogen level drops. So when a woman is delivered, after the delivery of the placenta, the progesterone level and the estrogen level will drop, and the prolactin level and the oxytocin level will then increase. So you want to determine if the patient is going to breastfeed or bottle feed. And also you need to know that milk production is a result of interplay of maternal hormones. So the anterior pituitary is responsible for the secretion of prolactin, and this prolactin is the hormone that is responsible for the production or the promotion of milk. And this prolactin promotes milk production by stimulating alveolar cells of the breast. Also, the oxytocin, which is another hormone that increases after delivery, is produced by the posterior pituitary gland, and it is necessary for milk ejection or the letdown reflex. So there is something called the letdown reflex. The letdown reflex is when a woman who is breastfeeding, if she is in a shower, she's in a warm shower, her breast milk starts to leak, the breast starts to leak milk, or she's thinking about her baby, she starts to leak milk. That is a normal phenomenon known as letdown reflex. And so it is the oxytocin that is responsible for the ejection of the milk and the letdown reflex, while the prolactin level is responsible for the production of milk. And so you have this question, when you go in to see your patient who have a baby and they just deliver the baby, most times, especially the first time moms, they'll ask you, oh, I don't think the baby is getting anything. I don't have breast milk. Well, tell them that they do have breast milk. There is something called colostrum, and that is the milk, that is the first milk that a woman makes. And the production of this colostrum begins in the second trimester when the body is getting ready for, the delivery and the feeding of this baby. This colostrum usually is seen around day 1 to 2 after delivery, and this colostrum is high in maternal antibodies. It helps to give passive immunity to the baby. So you always reassure the moms that yes, they do have milk. So you just have to help them to latch the baby onto the breast. And the more the baby sucks, the more it causes the milk production. And usually breast milk is seen more within 2 to 3 days, depending on the mode of delivery. For moms who had a vaginal birth, in about 2 days, their milk will come in more, unlike moms who had a delivery via C-section, because that C-section is not a natural way of having a baby. So the breast milk coming in might take a little more days in moms who had a C-section than moms who delivered vaginally. And milk production continues depending on if mom is breastfeeding. So if mom is breastfeeding, she'll continue to have more supply of milk. And moms who do not want to breastfeed or who do not wish to breastfeed, we need to support them too. So you need to tell those moms to get a well-fitted sports bra. So moms who do not desire to breastfeed need to wear a tight-fitting sports bra. So the reason why they have to wear this tight-fitting sports bra is to constrict milk production. They need to constrict milk production, and also they could use cold compresses. Cold cabbage leaves work as a charm. They could use that in order to constrict milk production. And of course, if you are breastfeeding, you want to teach moms who are breastfeeding to get a good nursing bra. It's not the time for Victoria's Secret unless it's a nursing bra. They need to get good nursing bra because they want to keep their breast in good shape. Remember what the law of gravity says. It says what goes up must come down. If you don't get a good nursing bra, sooner than later, the breast will start looking down the hill. So you always want to tell the moms they need to take good care of their breast. They need to wear good, supportive nursing bra if they are breastfeeding. And for moms who are not breastfeeding, they need to wear a tight, fitted sports bra to constrict the milk production. Involution. Involution is the process by which the uterus is transformed from pregnant to non-pregnant state. And so this process is primarily done by the hormone oxytocin. It is a term that we use to describe the rapid reduction in size of the uterus and the return to pre-pregnant state. And this involution is enhanced by uncomplicated labor and birth, complete expulsion of placenta or membranes, breastfeeding, and early ambulation. More to that, involution depends largely on three major things. And the first one there is the contraction of muscle fibers. So contraction of muscle fibers around maternal blood vessels at the area where the placenta was attached. That is one of the determinants of uterine contraction or uterine involution. So this basically helps to stop the bleeding. The second one is catabolism by the enlarged muscle cells of the uterus. And the last point is the regeneration of uterine epithelium. So these are all the things that the uterine involution solely depends upon. So involution begins immediately after delivery of the placenta. So if your patient delivered and the placenta is retained, the involution period or the involution process will not start. So that involution process will be hindered until whatever is left in the uterus is removed. So if your patient had a fragment, a membrane, a tissue, something left inside their uterus, the involution process will be hindered until that uterus is properly cleaned out. So during this process or during this period of involution, you want to after the delivery of your baby your patient, after delivery you want to during your assessment of the patient, you want to determine the location of the uterine fundus, because that helps you to assess if involution is actually happening or not. The day of delivery, you should feel the uterus at the level of the umbilicus. So if your patient delivered today, at the level of the umbilicus is where you will feel the fundus or the uterus. Post day one, or the patient delivered today, the following day is day one, you should feel the fundus, or you should palpate the fundus 1 finger breadth below the umbilicus, or 1 centimeter. So 1 centimeter equals 1 finger breadth. Day two, you should feel it, palpate it around it should be 2 centimeters away from the umbilicus, or 2 finger breadth from the umbilicus. And it continues until it finally descends into the pelvis. After day 9, day 10, you shouldn't be feeling the fundus. You should expect a non-palpable fundus, at least after the first 9 to 10 days, 12 days of delivery. You should not palpate a fundus. What you should feel upon exam should be a non-palpable fundus. Immediately after birth, the uterus usually will become like the size of a grapefruit. And so that is what you palpate. And remember when we covered pregnancy, I mentioned that every woman has a uterus that is very small. And when you get pregnant, due to the growing fetus, it stretches that uterus about 12 to 13 times bigger. So now after delivery of this baby, that uterus now becomes the size of a grapefruit. And where you will palpate the fundus is usually between the symphysis pubis and the umbilicus. So that is very, very essential for you to, palpate if you're doing assessment on your patient who had delivery. You need to palpate the fundus if they had a vaginal delivery. You need to, palpate the fundus. If they had a C-section, yes, you will palpate the fundus, but you have to do a light palpation of the fundus. The uterus. This is an image showing how the massage of the uterus is done. Prior to assessing the fundus, it is very vital to instruct the patient to empty their bladder, because we talked about the changes that happens. We said that it is normal for a woman who had a delivery to feel diaphoretic, also for her to experience diuresis. So now your patient delivered about 3-4 hours ago. Well, critical thinking will let you know that the patient's bladder should be full at this time. So it only makes sense that you ask them to empty their bladder before you assess them. So now if your patient is not able to void on their own, perhaps they had anesthesia, they had epidural, Well, you need to straight cut them because you know that a full bladder will cause the fundus to deviate to the right. Our bladder is very territorial. When it's full, it will cause the fundus to move to the side. So you don't want that to happen because if that happens, the patient is at risk for hemorrhage. If the fundus is difficult to locate or is soft and boggy, you need to stimulate the muscles to contract by massaging the fundus. And so that is the picture you're looking at there. So this examiner is trying to massage the fundus, and you use the non-dominant hand. So the non-dominant hand holds the lower part of the uterus, and you use the top hand to massage in a downward manner. Clots must be expelled in order for the uterus to continue to contract. So if your patient has a clot, it has to come out in order for the uterus to be nice and firm. So you need to massage the fundus until it becomes firm. If the patient fundus, after you have massaged it and you've emptied the bladder, fails to be firm, you need to call the provider immediately. And so when the provider comes, this will be a time for the provider to do the same assessment, massage the fundus. If the fundus fails to be firm and tonic, this will be a time for the doctor to now order some medications that we call uterotonics. And these are medications that we use to cause the fundus to become firm, well contracted, and midline. Drugs such as oxytocin. So every woman makes oxytocin. And the oxytocin that we make as women is known as the endogenous oxytocin. Is produced by the posterior pituitary gland. So that helps us to, it helps the uterus to contract. However, if the doctor ordered the pitocin or the oxytocin and it doesn't help to contract the uterus, there are other medications that could be used to stop bleeding. And the next medication that you need to know is called methogen. Methogen or methylagonovine is a uterotonics that we use in the setting of a postpartum hemorrhage. When a patient is hemorrhaging, we give methylagonovine or methogen to the patient. Now, this medication is not for everybody. It is contraindicated in patients who have high blood pressure because methogen can elevate your blood pressure. So patients who have gestational hypertension, chronic hypertension, pregnancy-induced hypertension, preeclampsia, eclampsia should not be candidates for methogen. You do not give it to them. Another medication that falls under the category of these uterotonics is known as Hemabate or Carboprost. Hemabate or Carboprost is a uterotonic that we use in the setting of postpartum hemorrhage. However, if your patient is an asthmatic, you do not give them Hemabate. Hemabate will cause acute respiratory distress on patients who are asthmatics. So you keep Hemabate away from your patients who have asthma. And also Hemabate, if it's given, can cause bad diarrheal effect or reaction on the patient. So the patient who received Hemabate can have a bad diarrhea. You know, whatever is in their guts, they will shit it out. So that Hemabate can cause that. And so when we give Hemabate, we give another medication called Lomotil. So the Lomotil is given in order to counteract that effect of Hemabate. Misoprostol is another medication that falls under the category of the uterotonics. If you remembered when we covered when labor induction, we said that we use some cervical ripeners. Misoprostol is one of the cervical ripeners that we use to induce labor. We also use it when there is postpartum hemorrhage. So the doctor will will place the misoprostol per rectum. So they'll put it in the patient's rectum in order to stop the hemorrhage. With misoprostol can increase your patient's temperature. It can elevate their temperature. So if your patient had meso and you check their temperature is elevated, remember that meso will elevate your patient's temperature. Oxytocin, as we mentioned earlier, is a medication that has a weak diuretic effect. So oxytocin can cause what is called water intoxication if a patient is on it for a prolonged period of time. So if your patient is getting oxytocin and they start complaining of shortness of breath, they start complaining of difficulty breathing, huffing and puffing, please stop the oxytocin, because that is a sign of that water intoxication and it needs to be stopped. So these are the medications that are given to stop to make the uterus to be firm if it is boggy, because if the woman if it's not taken care of, the patient can hemorrhage to death. So please do not forget those. Now let's talk about lochia. Lochia happens due to the endometrial healing exfoliation. So this lochia is what happens after, these are changes that take place after the woman delivers. The lochia is not the menses. So this is just all the debris that the uterus have to rid itself of. So the uterus rids itself of debris that are remaining after birth through discharge, that is called lochia. So the lochia changes from bright red at birth, it becomes rubra, which is kind of dark red, goes to serosa, which is pinkish in color, alba, and then clear. So these changes in the color and amount of lochia provide information about whether involution is progressing normally or not. So after delivery, from day 1 to day 3, the patient will experience what is called lochia rubra. So the lochia rubra is dark red. Usually, sometimes it comes with small clots. The clots can be dime shaped or quarter-sized clot, dime-sized clot, just small clots. Serosanguinous, then it becomes more serous and less bloody. So within the first 3 days after delivery, you will see the lochia rubra. Then from day 4 to day 10, the lochia serosa will pick up, and that is usually pinkish in color. By day 11, lochia alba, which is whitish and yellowish discharge, will continue, and it will run approximately from day 11 to day 21, and then clear. So you just have to tell the patient to make sure that they have to put on a pad. And the key things to remember about this lochia is that lochia should not go from rubra to serosa and back to rubra. If that happens, the patient is hemorrhaging. Neither will it go from rubra to serosa to alba and then back to rubra. If that happens, the patient needs to go to the nearest emergency room. That is a sign of hemorrhage. And so if blood collects and forms clots within the uterus, the fundus arises and becomes boggy, and that is called uterine atony. So it means that there is no tone to the uterus, that the uterus is atonic. So when that happens, the patient is hemorrhaging. So that is why it is very important for us to do that fundal massage that we mentioned in the previous slide. So now when you take a look at these two images on the picture, the first one, the one on the top, that is what a normal postpartum condition with well-contracted uterus that is firm and midline should be. And if the uterus is contracted and firm, patient will not experience hemorrhage. If you look at the bottom picture, that is what happens in the presence of uterine atony. The patient hemorrhages, and that is not good. So it is very important to pay attention to the patient after the delivery. During the delivery, if a patient had a vaginal delivery, it's expected that the patient should lose anywhere less than 500 cc's of blood. If a patient loses more than 500 cc's or 500 milliliters of blood, that is considered as postpartum hemorrhage in a vaginal delivery. In a C-section, the maximum blood loss is 1 liter. So a patient who loses more than 1,000 cc's or 1,000 ml of blood in a C-section have experienced a postpartum hemorrhage. Checking the patient's pad is very essential. So if you just change the patient's pad around 11 o'clock and the patient calls you back in the room by 11:30 and the pad is heavily saturated with blood, that is a sign of hemorrhage. It means that the patient is bleeding. So now, if you do an assessment on two patients, one who delivered vaginally and one who delivered via C-section, well, no doubt you will expect to see a heavier amount of lochia in a mom who had a vaginal delivery than a mom who had a C-section. Because in a C-section, the doctors will use the suction to suction the debris. So they get rid of the debris for the patient during the C-section. They'll suction the blood clots, the blood, the membranes, the fluid, everything. Unlike the mom who had a vaginal delivery, she had to get rid of all those things by herself. No one is doing the suctioning for her. So you will expect her lochia to be heavier than the mom who had a C-section, but it doesn't alter the flow of lochia, the process of lochia. It will still go through lochia rubra to serosa and to alba. The difference will be in the quantity or the amount of the blood. So you will see a scant lochia on moms who had a C-section and moderate to maybe heavy lochia on moms who had a vaginal delivery, depending on their parity. Now, sometimes moms will freak out if they're getting up for the first time. So that is why you have to let them know that the first time that they arise, the first time they're getting out of bed, whether they had a C-section or a vaginal delivery, that they may feel a gush of blood. And this is because of gravity. So all the blood that pooled while they were laying down, as they get up, it gushes out. So that is not, it shouldn't alarm them. You want to let them know that that is totally fine with the first time. Should that happen every other time they get up? Absolutely not. If that happens, then the patient is hemorrhaging. What if your patient is a postpartum patient? She delivered. You went to do assessment on the patient. The fundus is nice and firm, well contracted midline, just the way we love it to be. And the patient is still bleeding. And you're looking at her perineum, you see a steady trickling of blood. That steady trickling of blood is an obstetrical emergency. So you need to call a doctor immediately because you're looking at what is called cervical laceration. So your patient could be bleeding from a genital tract laceration. So the doctor needs to be called immediately. That woman can hemorrhage to death. But that is an obstetrical emergency. So risk of bleeding is very high during the postpartum period, as well as risk for infection. Urinary tract. Well, with the urinary tract, there is increased bladder capacity, decreased bladder tone, swelling, and bruising of tissue. So when a woman is pregnant, most women experience what is called stress incontinence. So the stress incontinence, if it happens to a woman who is pregnant, when she laughs so hard, she pees on herself. She coughs, she pees on herself. That is totally okay. But after she delivers, it should go away. So this is why we teach women to do what is called Kegel exercises. So the Kegel helps them to tighten the pelvic floor. So by doing Kegel exercises from time to time, it helps these patients to tighten up the pelvic floor. So postpartum diuresis leads to rapid filling of bladder. The patient may have urge to void. However, urinary stasis increases the chances of urinary tract infection. So that is why you want to make sure that you keep an eye on your patient's bladder. If the bladder is full, definitely it will move the fundus or shift it to the side. So once you have a deviation of the fundus to the side, that is a risk factor for bleeding. Also, moms who are new moms may want to void, but psychologically they will refuse to void especially if they had an episiotomy or they had a laceration that is repaired. So they will not want to pee because they know that it's going to, no, it's going to hurt when they pee. They'll feel that burning when they pee. So you have to encourage them to pee, because if they don't, a full bladder will cause them to hemorrhage. And if you're hemorrhaging, it wouldn't be fun once the doctors and nurses start doing intervention in order to stop that hemorrhage. So in order to assess that the mom is emptying a full bladder, a urinary output must be measured. So when a patient delivers, we usually measure the first 2 voids after delivery. At least we want to get about 300 to 400 cc's of urine in order to make sure that they are really emptying their bladder. If your patient had a epidural, anesthesia in intrapartum period can delay emptying of bladder, so the patient may not feel the urge to pee and they may have a full bladder. So you want to keep an eye on their bladder, because a full bladder will cause the fundus to shift to the side, and then that patient can hemorrhage. You want to assess the frequency of urination. Is it burning? Do they feel dysuria? The urgency. You also want to palpate the bladder for distension. Bladder should not be palpable. If you're able to palpate your patient's bladder, it means that their bladder is full. They need to go on void, because if they don't, it will impede involution. So always remember that a full bladder will impede involution. It will cause the fundus to shift or deviate to the right side, just as a full bladder will impede fetal head descent during labor. During postpartum, a full bladder will impede involution, and that will cause the woman to hemorrhage, and you don't want that to happen. Bowel, you want to ask the patient, assess them, check when was the last time they had a bowel movement. Some patients may have a bowel movement during labor or during delivery, and that's not a bad thing. The same muscle that we use to go to the to move our bowels is the same muscle that we use when we're pushing a baby. So if you had the opportunity to be in a delivery room, you'll probably hear the nurses and doctors say, push like you were going to the bathroom. So it's the same muscle. So if anything is on the way as the baby is making his or her grand appearance, it will come out. So if your patient is constipated or they had to move their bowels, they're bound to do it during delivery. There's nothing wrong with that. So you want to find out, and also you want to assure the patient that they need to. It's not constipation unless they haven't moved their bowels in about 3 days. Then they need to eat foods that are high in fiber, whole grain, fruits and vegetables, drink lots of fluid, and also ambulate. So those kind of things will help them with their bowel. And of course, if the patient is a C-section patient or moms who have hemorrhoids, the doctors will usually give them stool softeners such as Colis in order to help them to move their bowel, because those moms, we don't want them to Valsalva. And also moms who have cardiac diseases or cardiac disorders, we don't want those women to, Valsalva while they're going to the bathroom. So we have to help them. Diastasis recti abdominis. Well, this is the separation of the large abdominal muscle. During pregnancy, the growing fetus or the growing uterus puts pressure on the two bands of abdominal muscles that meet in the middle of the stomach, and this can cause these large muscles to separate. And so it's not uncommon to see this in pregnancy, because it occurs in about 2/3 of pregnancies, usually seen in women who are over 35, moms who are carrying multiple babies, macrosomic babies. Those things kind of put the patient at risk for developing or for having this diastasis recti. This is why we encourage moms to avoid heavy lifting during pregnancy, or even engaging in forceful abdominal exercises such as crunches. Those things need to be avoided because it will predispose a woman to experiencing this diastasis recti. You also want to inspect the abdomen during your assessment. Inspect the patient's abdomen. If they had a C-section, you're looking around the symphysis pubis, the lower area. That's where the incision will be made if they had a low transverse incision. And when you're doing an inspection of the incision, it's very important to use this mnemonic reader. R for redness, E for edema, E for ecchymosis, D drainage, A approximation. So the incision should not be reddened. If it is reddened, that's a sign of infection. There should not be edema around it or swelling. No ecchymosis, which is bluish, purplish discoloration, bruising thing around it. And nothing should be draining from the incision. No serous or pus-like substance, nothing. That will be an indication of infection. And the incision should be well approximated. It shouldn't be jagged or open. Patients, especially patients who are obese, are at risk for what is called dehiscence. And dehiscence means that the wound has opened. And if it's not taken care of, it can lead to evisceration when the organ starts to protrude. So these are important things that you want to keep in mind when you are inspecting your patient. And of course, you want to auscultate for bowel sounds. Remember, when patients had a C-section, their abdomen, the bowel sounds should be hypoactive. They had anesthesia, they were MPO, so you want to make sure that you auscultate bowel sounds to see if it has returned before you feed them. If there is no bowel sounds, you should not feed your patients because they run the risk of aspiration. There is no peristaltic movement. So due to that paralytic ileus, you could aspirate the patient because of that. So don't feed the patient unless there is a return of bowel sounds. And then because they had a C-section, it's very important to auscultate their lungs too. Make sure that the lungs are clear bilaterally to auscultation. If it's not clear, let the doctor know immediately. If moms had a perineal laceration, also use the mnemonic reader to inspect the area. You also want to assess moms for hemorrhoids. Hemorrhoid is not uncommon during pregnancy, and that thing can be very painful. So if they have hemorrhoid, they need to be helped. Or you want to offer ice packs to moms after delivery because edema is very common after delivery. So moms who had a vaginal delivery may have a perineal laceration or episiotomy, and it will have subsequent edema. So ice pack the area within the first 12 to 24 hours after a vaginal birth. This is very important. It helps to relieve the discomfort. It helps to reduce the swelling. You can offer TURKs, topical anesthetics, analgesics, and hemorrhoid cream as needed. Now, post 24 hours, you can offer sitz bath to promote healing of perineal area. So what you're looking at in this image is what is called sitz bath. So you look at the bag, it looks like an IV bag. You have to fill it up with warm water, and then you see the tubing, how it's run. Let the patient sit on the bowl and then hang the fluid. So now that warm fluid will be coming down, and as the patient sits on top of the bowl, it kind of helps to promote healing of the perineal area. So the warm moisture of coming from the fluid will help to promote healing of the perineal area. So this helps moms who have hemorrhoids as well. So you ice pack the perineum 12 to 24 hours after delivery to reduce edema. Offer sitz bags post 24 hours. Very, very important. And the anesthetic sprays also help to decrease surface discomforts and allow more comfortable ambulation. So moms who had lacerations, we give them topical anesthetics. There is something called a witch hazel pad. So you put that, lay it on top of their pad and you put it on them. It is very soothing. It helps to promote healing. We also have a peri bottle that we offer to women in postpartum. Those peri bottles are very, very helpful. So it's a bottle of warm water that is given and they squirt it over their perineum after each voiding and bowel movement. It provides comfort and prevents infection. It's important for postpartum women, whether they deliver vaginally or via C-section. So we give it to them to help them. Elimination. With regards to this elimination, the intestines remain sluggish because of the lingering effects of progesterone and decreased muscle tone. So during pregnancy, if you recall, the woman has decreased motility and that causes constipation. So you still have that lingering effect during the postpartum period. However, spontaneous bowel movements may not happen for 2 to 3 days after childbirth. Moms sometimes may anticipate discomfort because of perineal tenderness or fear of episiotomy tearing. So that is why when moms have a repair from lacerations or episiotomy, the doctors may give them stool softeners as well. And so elimination normally returns to normal within 1 week. And after cesarean section, bowel tone returns in few days, and flatulence causes severe abdominal discomfort. So when you do an assessment on your patient who had a C-section, we kind of ask them, have you passed gas? The reason why we do so is because during the C-section, the abdomen was open. So the air that got trapped in, causes gas. So that is very, very uncomfortable. That is why early ambulation is the key. As they get up and move around, it helps them to get rid of the gas. And most times too, we give patients a medication known as simethicone. So the simethicone, which is an anti-gas, it helps them to get rid of the gas. So we give it for gas relief. The extremities have to be assessed during assessment of a patient. You want to assess for pedal edema, redness, and warmth in the calf area. So the calf area, if it feels warm to touch, is inflamed and very tender, that's usually a red flag. So that patient needs to be assessed further because that is an indication of a possibility of having a DVT. So we used hormone sign, although hormone sign is kind of controversial because they said we may actually dislocate or dislodge the clot. But this hormone sign usually is pain that is felt upon dorsiflation of food. So once you feel that pain, it is considered to be a positive sign and may indicate thrombophlebitis. So if your patient complains of calf pain, by no means you need to call the doctor and let the doctor know. And also pedal edema may be present for a day or two until excess interstitial fluid is mobilized and secreted. Also, remember when you're assessing the pedal area, you want to keep in mind to check the pedal pulses, looking for making sure that they are symmetrical and they are present. In doing assessment of the peripheral area, we use the 5 P's of peripheral vascular assessment. The 5 P's are pain, pallor, pulselessness, paralysis, and paresthesia. So you may also use that as you do an assessment of your patient, checking the extremities. These are common postpartum concerns. We alluded to the first point earlier, that the first time a patient gets up, that a gush of blood, if it happens, is not uncommon. So when a patient gets up the first time, because of gravity, the patient may experience a gush of blood, and that is totally fine. But it shouldn't happen any other time or as she gets up again. A passing of clots is something that is common. You want to take a look at the size of the clot. A clot that is dime-sized, quarter-sized, that's not bad. But if it's heavy, you have a large amount of clot, then that becomes a concern. Earlier, we said that night sweats and chills are expected due to circulating white blood cells. Afterbirth pains. Well, the afterbirth pain is intermittent uterine contraction, and is usually felt more in multiparous women because the nulliparous woman's uterus usually remains contracted. And so these are due to the release of oxytocin when milk production is starting. So the oxytocin causes uterine contractions, and so analgesics are used to lessen the pain, and especially when moms are breastfeeding. So once the baby latches onto the breast, it sends a signal to the posterior pituitary gland to release oxytocin, and that oxytocin will trigger the uterine contractions, and that will cause that after pain. So giving the woman something for pain, ibuprofen, acetaminophen, that usually will help. And weight and large stomach, all the weight that a woman gained during pregnancy, she loses it after she delivers. Typically, the fetus, placenta, and amniotic fluid accounts for 10 to 13 pounds weight loss. And also, additional pounds includes 5 to 8 pounds, which is lost through diuresis and diaphoresis. And also from involution and lochia, you lose another 2 to 3 pounds. So that is how you lose all those weight you accumulated. And if you're breastfeeding, it's even better because you continue to lose more weight. Important facts about maternal labs. These are labs that are very important for you to consider or to check when your patient is in labor or during the postpartum period. We always check the blood type and the RH status. And the reason why we check the blood type and RH status, as we mentioned earlier, is because if mom is RH negative and she delivers, we usually do a fetal screen to check what the baby's blood type is. Now, if her baby's blood type is positive, that mom must be given RhoGAM within 72 hours postpartum. And the reason why we do that is to prevent the mom from becoming sensitized. So if we give it to prevent maternal antibodies that would now harm subsequent pregnancies. So this is very, very important. Hepatitis B is another important lab. If mom is hepatitis B positive, it changes the plan of care for the mom and for her baby. Moms who are Hep B positive should not receive internal fetal monitoring device. And when she delivers, it is very essential that her baby receives hepatitis B vaccine along with hepatitis B immunoglobulin within 12 hours of delivery. So within 12 hours of delivery, the baby must receive Hep B vaccine and Hep B immunoglobulin. HIV, well, as you recall, we said that HIV, all moms who are pregnant get tested for HIV. We do it in the first trimester, we do it again in the last trimester. Now, if mom is HIV positive, it changes her plan of care. Moms who are HIV positive, once they deliver, we usually don't check their baby's status immediately because it's hard to establish HIV in infants. And this is because of the antibodies, the maternal antibodies that may still be circulating. So those maternal antibodies usually will disappear on average around 14 days. So we wait about 14 to 21 days to test them. So now if you test the baby around 14 to 21 days and the baby's result comes back negative, well, we usually have to wait again till 1 to 2 months of life. The baby gets tested again. So this second time, if the baby tests negative, that is considered as a presumptive negative. So now we're presuming that this baby may be negative. Around 4 to 6 months of life, the baby gets tested again. So now this time, if the baby's result comes back negative, definitely the baby is negative from this virus. So now the baby will not be, will be ruled out for this HIV virus. Similarly, if the baby's results were positive, we have to wait again to do it. 1 to 2 months. If it's positive, we repeat it again 4 to 6 months to roll the baby in for HIV disease. If the baby, regardless of whatever it is, all babies who are delivered to moms who have HIV positive status must be started on prophylactic antiretroviral drug. So once the baby comes out, prophylactically, we start them on these medications. We give them Usually the drug of choice they give is zidovudine or lamivudine. So one of those they will have to give the baby orally until they're able to establish that the baby has HIV or not. Group beta strep is another lab that we have to really pay attention to. This group beta streptococcus, women are usually screened when they are about 35, 36 weeks pregnant. So this is bacterial colonization. If mom is positive for it, no big deal. It's not a sexually transmitted disease. We have to make sure that the mom receives penicillin for treatment if she comes into labor. Now, the mode of delivery determines if mom will be treated or not. If mom is having a vaginal delivery, she must be treated with penicillin. She needs 2 doses of penicillin. If mom is going for a C-section, she doesn't need to be treated with penicillin because generally when women are going for a C-section, they receive a broad spectrum antibiotics which gives them coverage or protects them prophylactically against infection. And moreover, the baby is not coming out through the vaginal canal in a C-section. So you don't have to treat mom for GBS if she is positive and she's going for section. But if she is delivering vaginally, definitely she needs to be treated. If mom is allergic to penicillin, we'll have to give her an alternative antibiotics. Usually they may give vancomycin. The doctor may give ampicillin or clindamycin. Rubella. Rubella is another lab that we check. If mom is rubella immune, that's fine. If she is rubella non-immune, it means that she needs to get the vaccine immediately after postpartum or during the postpartum period. So now these women, once she receives rubella vaccine, should avoid getting pregnant within 28 days of receiving this vaccine. Now for women who are MMR non-immune, if she has to receive the MMR, she needs to avoid pregnancy within 3 months of receiving the vaccine because they are all live virus. Maternal comfort. In order to promote maternal comfort, well, we have to relieve perineal discomfort. So we relieve perineal discomfort. We talked about giving moms the peri bottle, and usually that peri bottle is very helpful. We tell the moms if they are peeing, once they are urinating, they need to use it to squirt it around their perineum. Urine is very acidic, and if you're avoiding, if you're peeing when you have a laceration or a repair, perineal repair, it really hits the back of your brain. It really is painful. But as these women are peeing, if they squirt that, the water bottle around their perineum at the same time they are peeing, it helps to dilute the acidity of the urine, making it less uncomfortable. So that's one way we do that. And of course, we talked about the tugs, the witch hazel pads, the sits pad, all those things. You want to encourage early ambulation, monitoring them for dizziness and weakness, especially your moms who had a C-section or moms who lost significant amount of blood. Relief of after pains by the use of analgesics, and you have to give them analgesics before breastfeeding, usually an hour before breastfeeding. Medications and vaccinations, you need to remember, includes the analgesia. We use ibuprofen, acetaminophen. We give Toradol or opiates such as Percocet, oxycodone. Very important because you want to manage the pain. We talked about rubella, we talked about Rogam, and all the vaccines will include the Tdap or varicella, and we talked about the Metogen. And of course, you know your 5 rights prior to medication administration. So you know that I'm not going to go over that. Very important, you need to inform breastfeeding moms of risk and benefits of meds. So meds are compatible with breastfeeding, some are not. So that's always a concern of a mom who is breastfeeding. Before you give them any medication, they'll ask you. So you need to know that before you give any medication. Let them know and try to give them medications that are compatible with breastfeeding if they are breastfeeding. Special care for C-section moms. Moms who are Section moms, you need to remember that if they had a C-section and if they are breastfeeding, there are different types of breastfeeding positions, and we'll cover this when we do newborn. But especially the position that is favorable for moms who had a C-section is called the football hold. The football hold or the sideline position. So that is very, very comfortable for them. And of course, these moms will have a Foley catheter in place because they're not getting out of bed. The day of the C-section, we usually rest the patient, we medicate them, manage their pain, so they're not getting out from bed. So you have to have a Foley cath in place. The Foley cath should come out the next day so that they need to get up and walk. We talked about checking bowel sounds, very important. A C-section is a major surgery. You want to make sure that the patient doesn't have complications such as pneumonia, atelectasis, and you have to make sure that they use an incentive spirometer every 2 hours. Ambulation is tolerated. The stool softness recovered. Always listening to their lungs. Now let's shift focus to adolescent moms, teenage moms, and see what their needs will be. Well, the needs of these teenage moms largely depends on level of maturity. There are some teenagers who are really mature. They behave like mature people. So you want to assess the level of maturity, how much help they will need, support system, as well as their cultural background. You need to assess the maternal-infant interaction. They, forming bond with their babies, the roles of support person, plans for discharge. Definitely you need to put a social work consult for these teenagers. They will benefit from the visit of a visiting nurse service, home nurses, home health nurses who will come to the home to follow up with them. And of course, you need to assess the knowledge of child rearing. Patient education is very vital for this population, and plans for follow-up care is very, very important. What will make a woman relinquish a baby? Well, there are several reasons why a woman may decide to give up her ability to be a parent. So many reasons, such as social issues. And these social issues may include drug abuse, homelessness, adoption. So a woman who is a crackhead, she cannot even take care of herself. So these babies are vulnerable. They fall victims of circumstance. So that is one of the reasons why a woman could relinquish her right to parent her baby. Some women may opt their babies for adoption. So what is your role as a nurse? Well, your role is to be a support person. You have to acknowledge the situation, and we have to avoid being judgmental. It is not within our powers to judge anybody. We don't want to judge them. So be supportive as much as you can. Although it might be heartbreaking, but you just have to support their decisions. Postpartum teachings must be initiated right upon admission to postpartum unit. You want to assess the patient's previous knowledge, answer all their questions. They may have 1,001 questions. Be patient, answer them. Definitely postpartum and newborn care is a must. You have to do those. Now, after you have done some teachings and presented education to the patients, you need to ask them for a return demonstration, because that is how you ascertain that whatever you taught them, that they understood it. Because if you were teaching somebody to do something and they're not able to do it, you probably were entertaining yourself. So you need to ask for a return demonstration. Ask them to verbalize understanding of what you taught them. And of course, you want to give them printed information. You want to give them links to support group, numbers to call if they need further clarification or need help. There are some things that you need to teach them, such as uterine massage, involution, episiotomy care, nutrition, rest, sexual activity. That is very important. Due to that endometrial healing, no sex is allowed. They should not have any sex until at least 6 weeks. until the doctors have cleared them. They should not. I teach them about contraception, about medications, and always remember, whatever you teach, you need to document. If you didn't document it, you didn't do it. You also want to teach them about infant care and tell them about things to look out for. Fever, if there is a fever in a newborn is considered anything that is 100.4 and above. That is considered as a fever. Even in mom, I'll tell them about signs of inflammation, localized redness, pain of breast. They need to report that. If they have persistent abdominal tenderness, pelvic pressure, frequency urinary, urgency and burning sensation upon urination, they need to report that. If they feel calf pain, all those things, signs of infection, all those things need to be, taught to the patient. You need to document that you did all those things. And that is the end of this postpartum physiological changes. And I should be uploading this on Canvas as soon as possible.